Okay, thank you very much. Ladies and gentlemen, magandang umaga po sa kanilang lahat. Ito po si Iro Brillantes of Blueprint.ph will be the ones facilitating the press conference. Magandang umaga po. Press conference po nito ay ang OCTAResearch press conference wherein magkakaroon po tayo ng updates dun sa pinaka-latest na trends and figures po ng tinatrack ng OCTAResearch for the past mag-iisang taon na po. In a few weeks or in a few days, mag-iisang taon na po tayong nagkakaroon ng ating pandemya at ito po ay isa na naman pong report na gagawin po ng OCTA para po sa inyo. With that, let me first acknowledge the different organizations which have registered, no? Blueprint, Sandigan ng Demokrasya 22. We have CNN Philippines. We have Malaya Business Insight. We have Central News Agency, UST Hospital, PPHA. We have ABS-CBN. We have Chinese General Hospital. The Medical City Pangasinan, welcome po. Medical City, CGHMMC, FUMC, Bawan Doctors Hospital, magandang umaga po. Pedia MMC, magandang umaga po. MCUFDTMF, PCMC, Asian Hospital, dami nating mga hospital na kalahok po ngayon. PPS, PPHA, San Mateo Medical Center, Philippine Medical Association, Raba Consulting, Makati Medical Center, Central Luzon TV 36, magandang umaga po. Makati Medical Center, Senate of the Philippines, PPHA, University of Santo Tomas, Bena Enterprises, Philippine Information Agency, UST Hospital, Film Life, Asian Hospital, Business Mirror, Fatima University Medical Center, Cooperative Health Management Federation, PPS, ACT-CIS Party List, Nidea Law Office, Indra Philippines, Manila Bulletin, Eagle News, DZBB, Business Mirror, Maddox, TV5, Philippine Star, Philippine Information Agency, Mimaropa, GMA, DOH7, and IIEE. Maganda pong umaga sa inyong lahat. We have a very good attendance today. And with that, we will proceed po sa ating press conference proper. Let me introduce to you the person who will the person who will provide us with the numbers, the ones who is responsible for churning out the weekly numbers of OCTAResearch. He is a professor of mathematics and a biomedical engineer at the University of the Philippines, Diliman. He also served as coordinator for the Computational Science Research Center and became an adjunct faculty with the Asian Institute of Management. He was awarded one of 10 outstanding young scientists in 2010. Ladies and gentlemen, may I introduce to you Dr. Guido David. Thank you.
Yes, hi. Good morning to everyone who attended. Thank you for attending. So thank you, Iro. Thank you to the media partners, hospitals, government institutions, and private organizations. And I see some friends and faculty here. So I'd like to begin my presentation. So basically, we just like to talk about trends that we're seeing right now in Metro Manila specifically. So we're basically going to focus on what we're seeing in the National Capital Region. So just a disclaimer. So this is the current trend that we're seeing in NCR. And even if we're looking at the 7-day moving average, which is the orange line depicted here, we're seeing an upward trend. In fact, the upward trend is quite fast. So up until February 16, it's the day after Valentine's Day, or 2 days after Valentine's Day, we're seeing a flattish trend of about 400 cases per day. And then after that, the cases started increasing, and we're now at about 900 cases per day over the past 5 days. You will also see groupings of numbers that appear to be high, like 5 days, and this is due to the weekend testing. Generally, numbers are lower on or right after the weekend. So we see 2-day dips here. That's part of the pattern that we're seeing. But the overall trend is an upward trend. And just as a basis of comparison, this is the trend that we saw back in July to August. So this is when our numbers became so big in NCR that the health professionals had to call a timeout. So at that time, in late July, we were still averaging about 1,000 cases per day. Then by the first week of August, it jumped suddenly to about 2,000 cases per day. Now, these things do happen. We cannot predict sudden jumps like this. Sometimes it occurs when there's several super spreader events, but it could take just 1 week to go from 1,000 to 2,000 if the trajectory is fast. Now, we generally, when we project, we generally don't assume numbers to go that quick, but nevertheless, what we're saying is that it could happen. Now, what happened is that since August, the first week of August, the trend has generally flattened out. Or, I mean, we didn't flatten the curve, but the cases have leveled off. And this is, again, how we're looking at the reproduction number. Right now, we're seeing it at around 1.36, although there's reason to believe that this may be underestimated. These are just estimates. We have a range of reproduction numbers. And again, the reproduction number indicates how fast the pandemic is spreading. And if it's greater than 1, it's spreading fast, or it's spreading. And if it's less than 1, it's slowing down. And the higher the number, the faster the rate that it's spreading. So, and in general, this gives the average number of transmissions of an infected individual. So if the reproduction number is 1, it means each infected individual will infect one other person on average, okay? This is how, just as a comparison, this is how the reproduction number in Cebu City looked like over the past 2 months.
Look at the coronavirus.
So, hello. So just after the Christmas, the reproduction number was actually less than 1. Then it suddenly grew in a matter of about 2 weeks. Very quickly, it rose to 1.8. And then it has stabilized since then, and now it's actually decreasing. This is the good news for Cebu City. The reproduction number there is on a downward trend. Hopefully, it will continue going down, okay? But what we see here is that after the quick rise in the reproduction number in about 2 weeks, then we start a pushback, which is, this is when the local government implements measures that will that aim to contain the spread of the virus. So from January 9, they have already started implementing stricter measures as a pushback. And the effect of this pushback is that it will slow down the spread, but the slowing down is very gradual. And during this process, the number of cases will continue to rise because the reproduction number is still greater than 1. But as we reach this point, the pushback becomes stronger than the rate of spread, and the cases, well, the reproduction number will start to decrease rapidly. So here's another comparison. This is the reproduction number for NCR back in July to August. So we can see that before the timeout was requested, the reproduction number was bouncing between 1.25 and about 1.7. And then by the first week of August, it had already grown again to 1.8. It was the highest. And then when the MECQ was declared or implemented, then we see the reproduction number just decreased like a straight line. It just started decreasing and decreasing. And that is what we wanted to see. Even though the case numbers did not start to decrease significantly, it would seem like case numbers were still high at that time, and people were thinking that it was not working. It was actually working because the reproduction number was going straight down. And in fact, it was at this point, around end of August, when we declared that the NCR was flattening the curve. That means the reproduction number was already less than 1 at that time, or it was projected to decrease to less than 1, because sometimes there are lags in the measurement due to the testing. So this is just a snapshot. This is not updated. This was published 2 days ago, just to show you the cities with the highest number of cases. Cebu City still ranked first, but as you can see, the rate of increase has slowed down. In fact, it has leveled off more or less. Sorry about that. But and then there are several LGUs in Metro Manila, but most notably Pasay City, which is having a surge. So we're going to look at the specific cases of the LGUs in Metro Manila. And we grouped together the four highest, four LGUs with the highest number of cases. And here we see Quezon City with the green one, Pasay with orange, light orange, Manila with a darker orange, and Makati with a bluish bar. And we showed here the percent increase compared to the previous week. And we see that Pasay is obviously having a tremendous increase, 91% increase compared to the previous week. Now, what we normally look out for is an increase of about 40%. It could be a little less, could be a little more, it could be more, of course, which shows a significant increase. And that 40%, if it's on a 2-week increase of 40% each week, then we essentially flag this LGU as having a sharp 2-week rise. So here we have Pasay and Makati as having this sharp 2-week increase based on the numbers. So Manila is also having an increase, and Quezon City is also having an increase, but it may be slightly less than 40%. For example, the previous week, Quezon City had less than 40% increase. So even though those are also having increases, we're not yet flagging those as generally, when we are seeing a 40% increase, this is similar to what we saw in countries where variants were found to be spreading. So in other words, this is like a tracking mechanism to identify which places might have the variant, UK variant or South African variant. So here's the second group. And you can see that the caseloads for the current week are very similar for Navotas, Malabon, Taguig, Parañaque, Pasig, Valenzuela, and Caloocan. Although the sharp rise that we're observing, I think we flagged it in Malabon, Taguig, and Caloocan. We're not saying that the other LGUs are not suspect, but we're waiting for more confirmation, basically. But we're seeing also big significant rise. For example, in Navotas, there was a 1 week rise of 205%. And in Parañaque, it was a 1 week increase of 80%. So those are very significant increases. But among these, Pasig would be the LGU, which did not show a very significant increase. We would consider the increase, I would say it's slight, but it's moderate. So it's not a very significant rise. And for the last group, here only Las Piñas would have a close to a moderate increase, but it's not a sharp increase. And as you can see, some of the other LGs here are fairly stable or even decreasing, as in the case of Marikina had a decrease in cases. Mandaluyong had a 72% increase, but it's only over 1 week. So it's too early to tell. Okay, so those are some of the trends that we're seeing. But if we look at specifically some of these LGUs, like Pasay, this is the rate of increase that we're seeing in Pasay, and it's very significant. So in the early weeks of February, they were averaging only 20 cases per day. And now the average is, well, you can see it's around 150 almost, except for this 1 day here. I think the actual average is about 130 cases over the past week. So you can see this is a very fast rise. In Makati, we're also seeing an increase. It's a little slower compared to Pasay City. Here, the average was 30 for most of February, and then we have an increase, and now it's averaging more than 60 cases per day. So it's a significant increase, but not as sharp as in Pasay. Just to compare the reproduction numbers for these three, well, NCR, Pasay, and Makati, you can see the yellow line here shows the reproduction number in Pasay. It's already above 2, although it has started to, well, decrease, but it's still above 2, and that's significant. In Makati, it's almost at 1.7. And again, in NCR, we're measuring about 1.36. I checked ncove.ph, which is, I believe, they work with the Department of Health, and they have a similar reproduction number for Metro Manila. I think they have 1.38. So we have it more or less the same. They use a different indicator, I believe, onset of cases. And just to look at the positivity rate, this is the positivity rate for Metro Manila. Again, this confirms the increase that we're seeing. In early February, we were only averaging 4% positivity rate, which is a very good positivity rate. We've been holding 4% since October, and we haven't had an increase in positivity rate. Even in December, it did not really increase. But now we have seen the positivity rate go up to 6, and now it's almost at 7% average. So that is now above the 5% cutoff of the prescribed by the World Health Organization. So again, the positivity rate confirms the increase that we're seeing. And here are just some projections. The green bars here are the number of daily cases in Metro Manila, assuming that the 1.36 reproduction number continues. Now we illustrated 2 other scenarios. If the R increases to about 1.5, which it may already be at 1.5, or if it decreases to 1.2. And again, the ideal reproduction number R is less than 1, but sometimes we can't have what we want. But if it continues at 1.36, the more or less 800 cases per day will reach about 1,500 by end of March. So that will be essentially a doubling in the number of cases. This will be a lot of cases, but it will not yet overwhelm our hospital capacity, although we would want it to slow down before then, ideally. But if the reproduction number increases to 1.5, and it may already be at 1.5 because there's a margin of error in the calculations, then the number of cases will reach more than 2,000 by end of March. And this will already be a lot of COVID cases that the National Capital Region will have to deal with. This is a significant number, similar to what we saw in August. It will not overwhelm the healthcare system yet because of how fast it's spreading, but eventually it will. And the white line here represents a lower reproduction number of 1.2. We're not yet at 1.2, but if we can hold it down to 1.2 by implementing stricter, I mean, not stricter measures, but at least having a stricter implementation of our health protocols, among others, then it will still increase, but it will be manageable because it will increase very slowly, and we will be at just around 1,000 cases per day by end of March. And with the vaccines rolling out, that will play a factor in the future. Not yet, because we just have begun to roll out, but it will definitely be a factor that will help us manage the pandemic even further once the vaccine rollout is in full play. So I think that's it for me. So thank you. I think we will have the questions after the presentations of everyone.
Thank you, Professor Guido. Now let me introduce to you the next speaker. Ladies and gentlemen, he is a Filipino-American molecular biologist and a Catholic priest. He is a professor of biology and professor of theology at Providence College in Providence, Rhode Island, and a research fellow at the Center of Theology, Religious Studies, and Ethics, and at the University of Santo Tomas. He is also likewise our OCTA fellow. Ladies and gentlemen, may we introduce to you Father Nicanor Robles Austriaco, OP. Father, please.
Thank you very much, Ero, for that kind introduction. And hello, good evening from the United States. So I'm the biologist of the team, one of the biologists. And so as you know, yesterday, the DOH reported the first isolation of the South African B1351 variant in Pasay. And so we thought it would be important for me to give you a backgrounder on the two variants that we are currently facing in the Philippines, the UK B117 variant and the South African B1351. Here in the United States, they are called super COVID. So these are the super COVID variants. So I would like to begin by just talking about what is a SARS-CoV-2 variant. These are the most common variants that we are talking about today. So there's an original Wuhan strain that appeared over a year ago in China. We then have the B1 variant. The B1 variant is the variant that was responsible for the surge in the Philippines in July and August. So the Philippine Genome Center has confirmed that the surge we saw there was driven by this variant. And the pattern appears to be that in the Philippines, whenever we see a surge, the surge is driven by a particular variant that was introduced into the country. So the predominant variant today, the ancestral strain, is called B1 or D614G. This is the most common variant currently in the Philippines and around the world. We now have also the B117, the B1351, and the P1. As you know, yesterday we identified the P1351 South African variant in Pasay for the first time. So this is a map of the geographical distribution of the three variants of concern as of a couple of days ago. So the B117 variant is the most common variant. It is now found in 94 countries, including the Philippines. The B135 variant is in 48 countries. And on this map, you do not have the Philippines colored pink yet, because this map was drawn out before the report. And then the P1 variant, the Brazilian variant that appeared in the Amazon, thank God, has not yet been identified in the Philippines. So in order for you to understand a variant, you need to understand the virus. So this is a drawing of the SARS-CoV-2 virus, and the virus on its skin has 75 spikes. And one of the spikes is indicated in the slide. And this spike is the key that the virus uses to enter our cells. So in this particular picture, you have a virus that is approaching the skin of a human patient, and our skin is covered with the lock that the key can fit into. So if the key is in red, the spike protein, the lock is called ACE2. And ACE2 is found in the respiratory system, but it's also found in the intestine, which is why so many COVID-19 patients often struggle with diarrhea. So you have an infection in the respiratory system, but you can also have an infection in the gut. What happens is that when the virus approaches the human cell, it will insert the key. So it will take the SARS-CoV-2 spike protein and it will attach it to the human ACE2. So you have a key and a lock. And once this key engages the lock, the virus is able to open the cell and enter the cell, injecting the cell with its RNA to make more viruses. Now, to understand a variant, you have to understand that the variant is a change in the key. The variant is a change in the spike protein. So on the left side of the picture, you have the original spike protein, the original key. And here on the right, you have several changes in the key, in the B117 variant, that allows it to open the lock more efficiently. And the reason why this variant is able to transmit itself frequently and faster from one person to the other is because it has a better key. And so the two variants we're talking about, B117 and B1351, both have better keys, and the key is able to open your lock, which is why it's more transmissible. So one of the things that we would like to highlight is that variants have triggered significant surges around the world. So on the very top, you see the pandemic curve. So on the vertical axis, you see the number of cases every day. And on the horizontal axis, what you see is the date. And you can see that around January of 2021, so during the new year, the United Kingdom, Israel, and Portugal experienced dramatic surges that were driven by B117. In South Africa, you can see that when the 1351 variant became dominant in Africa, you had a significant surge that was higher than any of the original surges in the pandemic. This is a particular hallmark of a variant-driven surge. So when we speak about the B117 variant, what we know now, it is about 50 to 70% more transmissible. So you can see higher numbers of people in a household who are infected when one of their loved ones is COVID-19 positive. And so it's higher, it has a higher infection rate. There's also data that suggests that it is more transmissible amongst children. And this was first pointed out in the United Kingdom because during their lockdown at the end of last year, they still allowed their children to go to school, and they noticed that more children were actually getting COVID-19 positive. And it turned out it is because of the B117 UK variant. So just so you know, you may or may not know that the countries of Jordan and the Czech Republic are currently suffering a surge. Each of them is suffering a surge. You can see right after January, you see the surge in the pandemic curve. It's going up. This is both driven by B117. It's been confirmed by genome sequencing. And in both of these countries, the governments had to reimpose lockdowns of different intensity to contain the pandemic. Now, one of the things that is so striking, if you look at the pandemic curve for Region 7, Central Visayas, which includes Cebu City, which my friend and colleague, Professor Guido, just discussed, if you look at the curve, you will see that the curve looks like many of the other variant-driven curves. And of course, we know that the Philippine Genome Center has confirmed that B117 is present in Cebu, in the Central Visayas. So one of the reasons why you see such a sharp increase in the number of cases is because of this B117 variant that is more transmissible. And one of the things that we would like to highlight, one area of concern, one reason for our concern, is that the ongoing surge in Pasay and the NCR has the hallmark of a variant-driven surge. As Professor Guido pointed out, you are seeing dramatic increases in weekly numbers in many of the NCR, many of the LGUs of the NCR. And when you see this pattern, especially it's repeating itself in more and more LGUs, you are very concerned that what you're dealing here with is a variant. And of course, yesterday, unfortunately, the DOH confirmed that for the first time, we have the first detection of the B1351 South African variant, which drove the surge in South Africa and many of the surrounding countries around South Africa. However, the most concerning thing about the B1351 variant is that the B135 variant can resist the AstraZeneca vaccine. So this is a paper that was published at the beginning of February from a laboratory in South Africa. And the efficacy of the AstraZeneca vaccine against B1351 dramatically decreases from 70% to 10%. And basically, South Africa decided to abandon the AstraZeneca vaccine because it was no different than injecting water into the patients. Because with 10% protection, basically most people would still be able to get mild and moderate COVID-19. So this is the concern. If we do not eliminate the B1351 variant in the Philippines, which was first identified yesterday in Pasay, the 17 million doses of AstraZeneca that we have already bought but have not yet arrived will be ineffective against fighting this particular variant from South Africa. Furthermore, we would need 3 doses of the remaining vaccines because you would need 1 extra dose, 1 booster shot just for the 1351 variant. So I would like to end. So I received the 2nd dose of the Moderna vaccine last Friday here in the United States. And we have already been told that we should expect to be vaccinated for a 3rd time in September or October with a new booster from Moderna specifically to address 1351. And so we in OCTA thought it was important for the media to understand the impact of the first detection of the 1351. It is not just about pandemic control. It is also about the impact of this variant on our national vaccine strategy that we have just begun. So we have just begun, and we have already been hit in the stomach by a variant that will, if it is not controlled, if it is not eliminated from the islands, will severely impact and make it more difficult for us to vaccinate the 75 million Filipinos in order to acquire herd immunity. Thank you very much for your kind attention.
Thank you very much, Father, for that very enlightening presentation. Now, we will proceed with our topic on vaccines as a segue from the previous presentation. The next speaker is the Chief of the Section of Infectious Disease, Department of Pediatrics at UST Hospital. He's the chair of the Pharmacy and Therapeutics Committee at Cardinal Santos and chair of the International Review Board of the Asian Hospital. He's our fellow from OCTA. Ladies and gentlemen, Dr. Benjamin Ko. Doctor?
Hello, good morning, everybody. Let me try to share my screen. All right. Thank you, Father Nick, for that introduction. At least it will not make my lecture more complicated. I'm just going to give you guys a summary of what you need to know about COVID-19 vaccines. And this is a picture of where we are globally with the COVID-19 vaccines. And this is taken from the New York Times. You will see that there are not all of the vaccines actually go through being approved. Some of them are abandoned by the manufacturers eventually, but 6 have been approved into full use, 6 authorized. There are 20 that are still in phase 3, 28 in phase 2, and 41 in phase 1 of the clinical trials. It's important to know the various stages because preclinical testing is vital, and we know for a fact that the preclinical testing is used in animals. It's when we're able to demonstrate that there is an immune response in animals, and we're able to demonstrate the ED50, otherwise known as effective dose, for 50% and lethal dose for 50% of drugs and vaccines and other biological agents in the animal models, then we know that it can be demonstrated in human beings. So that's the only time that after there's an immune response and determination of safety and lethality and carcinogenicity and embryogenicity and mutagenicity in animal studies do we go into phase 1 clinical trials. Phase 1 are safety trials, phase 2 are expanded, phase 3 are efficacy trials. And then of course there is the early or limited approval phase, which includes the EUA. And then there is the full approval for the various vaccines. And of course, you have the abandoned phase. I'm sure you're all familiar too with some of the vaccines getting paused eventually. Like for example, AstraZeneca was one of the vaccines that were paused in some of the clinical trials because of adverse events, but later on was allowed by regulatory bodies to continue with their clinical trials. It is the same thing with Sinovac, which had a pause initially, but was allowed later on by the regulatory bodies to go through the clinical trials because there were no problems. Actually, it was not related to the vaccine. So this is the status of approval for many of the candidate leading vaccines. You will notice that they are all in phase 3, or for some of the vaccine trials, a mixture of phase 2 and 3 of the clinical trials, particularly for Pfizer's BioNTech and AstraZeneca Oxford vaccine. Majority of them have approval from the regulatory agencies, especially mature regulatory agencies for emergency use. Johnson & Johnson has recently been approved for EUA from the US, and this is one of the better vaccines because it's a single dose vaccine. As a matter of fact, it's not only in the US that it has received approval, but also in Bahrain. Novavax, which is a protein subunit vaccine, is not available yet, but early clinical trials have shown that it is one of the more effective vaccines, including those that address the strain that Father Nick was talking about on the B.1.35. They're divided into different platforms. The most common are the messenger RNA, which are Pfizer's BioNTech and Moderna. The viral vector vaccines include Gamaleya Sputnik V, AstraZeneca Oxford vaccine, the CanSino vaccine, and Johnson & Johnson's vaccine. The Sputnik V is unique in the sense that it uses 2 adenovirus platforms, the first dose uses adenovirus 26 and the second dose uses adenovirus 5. CanSino biologic is a single dose as well. The same thing as with Johnson & Johnson. The others are the protein subunit vaccines, one from the Vector Institute in Russia, and the other one is Novavax. And of course, you have the inactivated vaccines, Sinopharm, Sinovac, Sinopharm Wuhan, and the Bharat Biotech. And let me show you also in the next slide a summary of what the data show currently. So far, the data show that the number of doses for the various vaccines that have seen approval are on the majority of them are at least 2 doses, whether they are given 3 weeks apart, like the Pfizer, or 4 weeks apart, like Moderna, Gamaleya, Sinovac, Novavax, and Sinopharm, or they are given 12 weeks apart, as in the new data for AstraZeneca Oxford, in order to improve its immunogenicity. The 2 endpoints, and I'd like everybody to remember that are in the clinical trials are always one. These 2 are the 2 endpoints. One is the prevention of symptomatic clinical disease, which means that you're not going to come down with any symptomatic clinical disease, whether it is mild, although it will not be able to detect whether you have asymptomatic COVID or not. So the 2 endpoints are, one, on the prevention of symptomatic clinical disease, and the second endpoint on the prevention of severe disease. I did not include the last column here on the prevention of death, but the data showed that none of those that received any of the vaccines resulted in death due to the vaccine. So they did not develop COVID and they did not develop any deaths from the vaccine. If you look at the prevention of symptomatic clinical disease, they have a different variety of percentages. These are actually median percentages with a 95% confidence interval, and I'll explain that to you in a little while. None of them, none of the vaccines are able to demonstrate herd immunity because it is too early in the clinical trials to demonstrate any form of herd immunity. That's one. The second problem we will get with demonstration of herd immunity is it's not approved in children. And if you're going to talk about 70% of the population getting immunized, I don't think that's going to be possible in countries where you have a very large population that are 18 years old and below, if the vaccine is not yet approved in the pediatric population. And third is the fact that for SARS-CoV-2, unlike the other vaccine preventable diseases, this is one virus that has an animal reservoir. So this might pose a challenge later on into achieving complete herd immunity. I would prefer to use the word herd protection. And then, of course, there is the issue of vaccine hesitancy. You will have to remove the percentage of people that refuse to get the vaccine, and therefore you might not be able to achieve herd protection for the population at large. With respect to Philippine FDA approval, none of them have been approved for use except for 3 which have received emergency use authorization. With respect to storage instructions, the most ideal in areas like the Philippines, wherein you need to use them, you need to store them at 2 to 8 degrees centigrade, would probably be the viral vector vaccines, the inactivated, and the protein subunit vaccines. Only 2 of them will need to be frozen, while Pfizer's BioNTech recommends it at -70. Pfizer has applied for new stability refrigeration storage instructions, which means that They have evidence now that it can be stored between -15 to -25. So they've applied for application for change in label with the US FDA. We will need for the US FDA to approve that change before we can store it at that particular temperature. So let me summarize the issues and perspectives on the vaccine rollout. Are the vaccines the solution to reopening the economy? They're only part of it because we have issues on vaccine hesitancy. And you have to remember that in any disease, for that matter, prevention is only part of the solution. The other part of the solution include trying to address the treatment to this particular pandemic, this particular virus in this particular pandemic. And it's quite a challenge because we have no treatment currently. And of course, the political issues. Trials in children have barely started. There is no approval for this age group. There are two vaccines that have gone through clinical trials in children. These are Pfizer and Sinovac, but they're in the very early stage. The question some people ask is why don't they start the trials in children as well? The answer to that is that there's a shortage of vaccine globally, and therefore it's not prudent to start clinical trials in children until there's access to vaccines in all age groups. And then there's always fitting the numbers. We say 95% for one, 35%, 55% for the other one, and so on and so forth. And let me remind everybody that the timeline of the clinical trials are not the same. There are differences in circumstances, there are differences in recruitment. For example, for the vaccine Novavax, they were able to demonstrate that there is a certain percentage, actually 60%, efficacy against the South African escape variant, because at the time that they were doing the clinical trials in South Africa, this was already the virus this was the variant that was circulating at that time. And you see the difference also with the AstraZeneca Oxford vaccine in the clinical trials done out of the UK. When they were doing this out of the UK, they were able to subdivide the population and say that, all right, for the ordinary virus, the SARS-CoV, the original SARS-CoV-2, it was 95.2% effective, but with the B117 strain, it was 85% effective only. So it will depend on when the clinical trials were done, the circumstances in the recruitment, and the population of the clinical trials should be similar. There is a major shortage issue on vaccine supply, and then somebody has popped up the question on doing clinical trials and how ethical it is at a time when vaccines are already available and one will need to get recruited into the placebo arm. And then, of course, there is the single dose for those who have already previous COVID. So this is interesting because there are suggestions that patients who have had previous COVID may need single doses, and the data for this is very early. And of course, retrofitting other clinical trials for longer intervals, which AstraZeneca has done. I'm glad Father Nick has raised the issue that the AstraZeneca Oxford vaccine actually, when used in South Africa for the B1.135 strains, has shown only 10% vaccine efficacy. That is actually the data that came out. And so that is the reason why South Africa put the AZ vaccine on hold for a while in the country. And then there is the development of single doses, which are more appropriate because it's really very hard to make people come back and forth. And of course, the variants are here. So they're retrofitting and redesigning a booster shot that will address these variants. There is a guide to who and to when to get the vaccine that the WHO provides. And those that are not indicated are those that the children that are less than 16, those who have allergies to polyethylene glycol or polysorbate, and those who have anaphylactic reactions after the first dose of the vaccine. Otherwise, aside from that, anybody else can get it, except that if you have certain conditions, there are just special precautions, or if you have certain diseases at the time that you are supposed to receive the vaccine, or certain health conditions like pregnancy, you may elect to defer it. For those who have autoimmune diseases diagnosed with HIV, cancer, have undergone transplant or steroid treatment, or at the end of life, these are issues that you might want to get clearance from the attending physician. Or if you're bedridden and you have a terminal illness, you may opt not to get the vaccine anymore. My last slide is, and I will borrow this from Dr. Patrick Moral, and I think this is very appropriate at a time like this. The choice to get vaccinated is almost universal. The choice on which vaccine is personal. Let's not shame or feel superior to those who choose to wait, as we do not walk in their shoes. In the same way, let us not sneer at those who have chosen to get vaccinated, as they see it as part of the greater good. Everyone wants this pandemic to end, and we are rational beings, and the choice should always be given. Thank you.
Thank you. Thank you very much, Dr. Ko, for a very enlightening presentation. Then for our last presenter, may I introduce to you, he's a political science professor and assistant vice president for public affairs of the University of the Philippines. He's also the founder of OCTAResearch. Ladies and gentlemen, Professor Ranjit Rai.
Yes, good morning to everyone, and thank you to our earlier presenters, Dr. Guido David, Dr. Benji Ko, and Father Nick Austriaco, all of whom are distinguished scientists in their own field and medical practitioners and practitioners in their own field, and as of course fellows of OCTAResearch. Before I start and preface my discussion by saying that OCTAResearch has been doing its monitoring since the start of the pandemic. We've been observing it the whole of March, and we came out with our first monitoring report.
No volume for Ranjit, right?
Yeah, can you hear me, guys? Yeah.
Yes,
can
we
you
can
hear me?
hear you.
Yeah, okay.
Yes.
So I was just prefacing my presentation by saying that OCTAResearch is here to provide for the public the best possible data on the state of the COVID-19 in the country. And we've been doing this since March last year. And we started with bi-monthly monitoring reports in April, and we've gone to weekly reports. So again, this has to be appreciated in a sense that we're doing this on a weekly basis. And when we see significant changes in the trends, people often look at the numbers at the end, but small as they may seem and manageable as they may seem, what we're looking at in OCTA is the trend. And if the trend is going up, we let the public know. And we see when we see things, changes, we inform the public, and that includes, of course, government and the private sector. OCTA, just like all other entities in our society, our stakeholders, want us to get to a new and better normal. We want to open up the economy and at the same time deal with the management or mitigation of this virus that has plagued us. So this is the preface to my presentation. And so we've heard the previous speakers. And what we are trying to say here is that we are, number one, in a early stage of a potentially serious surge. We've dealt with surges before. We have improved their capacity. The Philippines in general and the NCR is better prepared now to deal with surges, both at the level of testing, tracing, isolation, and even treatment, as Dr. Benjico was trying to say. But there are mitigating circumstances and elements to this particular surge. Now, there are nuances. One is that we're dealing now with, as Father Austriaco was saying, new variants that are game-changing variants. Not only because they're more contagious, not only because they're more lethal, but they have a significant implication on the rollout of our very important vaccination program. Be that as it may, as we are in the early stages, we believe that whatever is happening now in the NCR can still be mitigated if we all work together. Okay, the situation is still manageable. What is required is really timely and appropriate responses, not just from government, not just from our local governments, not just from the private sector, but from us individuals and citizens. So this is where we're coming from. We see a significant rise in cases, and we're at a time when we have identified serious variants, okay, now spreading all over the country and including the National Capital Region. As to the prevalence of these variants, we're still waiting for the DOH. We're still waiting for our epistemic or scientific communities, institutions like the Genome Center to confirm. But what we see is really what we see from the data, from the numbers. And as the Professor David has pointed out, the signatures seem to point to a possible spreading of these so-called more contagious and lethal variants. Next slide. So we again, the focus is on what we can do. Okay, the first and foremost for us is that we go back to the basics. No, the best science is telling us that if the national and local governments work together, they can intensify testing, tracing, and isolation. Okay, and we believe that doing this and doing this well will actually help mitigate and possibly reverse the increase in transmission in communities, whether it's the UK variant or the South African variant. Okay, we cannot move forward without improving, no, and intensifying our testing, tracing, and isolation. If we test and identify, but we don't isolate at the local government level effectively, the virus will continue to spread, and that's why we're appealing to our local government units to be more vigilant, to continue and even intensify, okay, the efforts of testing and tracing. Tracing will be very important here, okay, and as it has been important in a sense, no, in other places around the country, in minimizing the spread of certain variants. Okay, we saw that tracing was very important in Mountain Province. We're seeing that it will be important in key cities around NCR, and so we're encouraging local governments to continue testing, tracing, and of course to expand isolation. Second is, while we are not advocating large-scale lockdowns, we are one with government that we want to open up the economy and find a proper balance, no? But given the context that we are in now, there's a possibility of a more contagious variant or set of variants becoming more prevalent. It's incumbent on our local governments, no, especially in the high-risk areas identified by Professor David in his presentation, to use, no, localized barangay-level lockdowns, as was undertaken by Pasay. And we hope that very soon we'll get data to see if it was effective, no? And localized lockdowns might be the way to go as far as containing these new variants are concerned. However, we in OCTA, as we have suggested and reiterated in all our monitoring reports, localized lockdowns are hard. Lockdowns in general are hard for communities. So that's why we're advocating that these lockdowns are humane, they're supported, okay, and that they're localized but given a particular time frame. And we feel that if effectively undertaken, it could be a step to fight against the spread of these more contagious variants. Next slide. Okay, this is very important, no? And we echo the position of the Department of Health on this issue also. I mean, while the LGU has particular responsibility both in terms of testing, tracing, and isolation, it's important that LGUs also monitor and strictly enforce minimum public health standards, such as the wearing of face mask, face shield, the enforcement of social distancing, and of course, the encouraging of proper hygiene. At this point, we really need to emphasize this. No? Now more than ever, given the fact that there is a significant rise in cases, we call it a surge in OCTA, and that there are complicating circumstances because of the variants. Okay. Next slide. Okay. So here's what we want to emphasize, no? Based on the data that we have and the observations of the trends, no, here in the NCR around the country, and also reflecting on data in our last surge here in the National Capital Region around August. Okay, we believe that there is a surge. Okay, it's in its early stages. It's not anymore a question of if, but really how serious, no, this surge will be. So it is in this slide that we urge the national government to increase the capacity of our healthcare system, no, both not just in beds and bed capacity, but manpower also. Okay, and to increase, of course, testing. I think it's still an issue. No, we need to not rest on our laurels, no, and further increase testing, because it's only through testing that we can identify infected individuals. I'd like to add, no, that biosurveillance is a key national concern now. It's a national security concern. The ability to do gene sequencing quickly, no, the capability of both the National Capital Region and the country in general, no, to undertake biosurveillance. It will be an important capacity, okay, core competence as we move forward, as we continue to manage this pandemic. Next. Okay, I've emphasized this. No, the national government needs to scale up contact tracing, not just in the NCR, but all over the country. We know that it has improved a lot over the last 6 months. It needs to further improve and expand over the next few months, especially as we are now rolling out the early phases of our vaccine deployment program. Okay, again, isolation facilities are important. Okay, and of course, I emphasize is to improve LGU's capability to undertake surveillance. So these are the elements in our recommendation that were standard in most of our monitoring reports, but we feel that we need to reiterate this, especially now that we're seeing massive increases in cases in the National Capital Region. Please take note that while it is not yet in all cities, we're seeing that the trend is going up. The reproduction number is above 1, and that we feel that the virus is spreading. No? And given that there are variants already identified, we suspect that some of these variants, no, or that these variants, the 2 variants, may be driving the infection or the increase in COVID-19 infections in many of the LGUs observed. Next. Okay, during this time or period of surge, the private sector needs to realize that it continues to play a very significant role. Okay, and that is to reduce the risk of workplace transmission. So now more than ever, we have to be strict in private sector workplaces, in malls, no, most especially. Now is not the time to loosen restrictions. Now and to loosen our protocols for monitoring and surveillance. In fact, now we need to be even stricter. Okay, I've seen many business establishments, because of the cue that they got from the national government, are now more lax, no, as far as monitoring and monitoring compliance with minimum health standards are concerned, and even basic taking of temperature and the writing down of contact tracing information. So we need to ensure that. No, we also need to encourage the private sector to increase testing while we're waiting for the vaccines to come. No, to increase even more testing capacity. We have now new modalities for testing. The saliva test is one. No, and we encourage the private sector to invest in their employees by increasing testing. The more testing that we can do for our workers, the more of them will come out and rejoin the economy. So we're batting for more testing. We've increased it, but we can do even more, and the private sector can help in that. Next. Okay. This is a call, really. Given that a surge is happening, given that it still can be mitigated and it's still in its early stages, we do feel, given the projections provided by Professor David, that there will be a significant increase by the end of March. Okay, and given that a portion of this will likely end up in the hospitals, we encourage, while the surge is still manageable, we encourage all our health workers to get themselves vaccinated with the available vaccines provided by government. We know that some of them are already have set their minds on other vaccines that have yet to come. But given the context that we have at the moment, there's a window of opportunity before this surge hits our hospitals, and we encourage our healthcare workers to get themselves vaccinated while the situation, as far as the surge in the NCR is concerned, is still manageable. So with that, we open the floor to questions. Okay. Okay. I'm sorry. The last point, we feel this is important to emphasize, and we know that because of the surveys OCTA has conducted on COVID-19 all over the country, we know that there's a very high compliance with minimum health standards, public health safety protocols like wearing of masks, in particular. But we encourage our citizens now at this time when there is a rise in cases to go back, to being conservative, and to avoid crowded and enclosed areas, to refrain from organizing social gatherings, and to practice minimum health safety protocols like wearing of masks and face shields. Now, remember, we are going to release in the next few days the results of our survey, a nationwide survey on the practice of safety, public health safety standards such as wearing of mask, face shield, and social distancing. Initially, I'd like to let you guys know that while most people practice the minimum health standards, they don't practice it every day. In fact, a majority of people wear face masks, but it goes down. The number goes down as we talk about face shields and social distancing. And these three basic elements of the minimum public health safety standards have to be maintained on a daily basis, on an everyday basis, until we have vaccinations for everyone in place. So we want to emphasize this. There's a slackening off. There's a deterioration in compliance as far as face shields are concerned, as far as social distancing is concerned. And we saw it in the survey. We will come out with the press release by tomorrow, for all our media partners. And lastly, we'd like to emphasize, that moving forward, what we do as individuals, as citizens, okay, is more important than anything government does in this period of surge, in this period of uncertainty and spreading variants. What we do as individuals will spell the difference, as far as fighting COVID-19 is concerned. So we encourage our citizens to continue to do their share by being vigilant and disciplined in following the minimum health standards set by the DOH. We continue to encourage our citizens to take part in discussions like this, to inform themselves of both the information about vaccines and to consider very seriously to get themselves vaccinated. Our last press release on vaccine willingness in the country is not very good. Only 19% of adult Filipinos all around the country in a nationwide survey are willing to get vaccinated. 46%, on the other hand, have decided not to get vaccinated. So it is in this light that we encourage individuals, citizens, to take part in programs that will inform them about the importance of getting themselves vaccinated. And we exhort the Department of Health to roll out over the next few weeks, given that our vaccine deployment program will take some more time to hit the regular citizen, to start informing citizens about the importance of getting vaccinated. So with this, I'd like to end our presentation and open the floor for discussion. Thank you.
Yes, thank you very much, Professor Rai. We'll now open the floor for questions. We have a lot of questions in the chat room and would like to go over them one by one. But aside from that, you may also raise your hand and have your questions live. And just prompt us so that you may speak. And we will provide all of the participants with presentations that were given by the various presenters, and we will email them to you. For those who have not registered, please register, and we will provide you the materials. With that, we will proceed with our first question for Father Nick. Father, since hindi po effective ang AstraZeneca sa South Africa variant and NCR cities, but many AstraZeneca, ano po ang advice ninyo na vaccination strategy? Ano pong vaccines ang okay?
So my response to that is that we still have a window of time to try to eliminate the B.1.351 variant from the NCR. And I'm hoping over the course of the next couple of weeks, we will actually be able to do that. If we are not able to do that, then we will have to have another conversation about which vaccines are available to replace the 17 million AstraZeneca doses that will become useless in the Philippines. Of course, this discussion will depend upon the very limited supply of vaccines overall. So right now, I'm hoping and I am praying to God that the Pasay City, with 77 barangays in an ECQ-like lockdown, will be able to contain the spread of that variant. But we will not be able to know for another week or so, because from what I understand from the news, genomes from Pasay have just been sent to the PGC, and it will take a 1 week turnaround to know what the extent of the 351 variant in that LGU.
Thank you, Father. And then for Professor Guido, ano po mas mabilis na transmission o pagdami ng cases sa Pasay NCR or sa Mountain Province or Cebu?
Yes, thank you for the question. So if we base it on the reproduction number, actually the reproduction number in Pasay is higher than in Cebu and in Mountain Province. So in Cebu City, it peaked at around 1.7 to 1.8. In Pasay, it was already above 2. It's now stabilizing a bit. But definitely the rate of infection is faster in Pasay compared to Mountain Province in Cebu. I don't have the exact numbers in Mountain Province, but it's about similar to what we saw in Cebu City. So it means that something is driving it faster. Now, of course, if we look at the entire NCR, it is averaged out. So the reproduction number seems lower. We're seeing it at 1.36. It could be up to about 1.4 or even 1.5. But it's lower because not all LGUs are experiencing this surge. So it's mostly concentrated in Pasay and a few other LGUs surrounding Pasay. Parts of these LGUs and in northern Luzon. So I hope, northern Metro Manila. So I hope that was helpful.
Okay. For Father Nick, what is the window period before the new variants become dominant if the reproduction RT holds?
Thank you for that question. In order to answer that question, we would actually have to model the spread of the variants in relation to the current dominant variant in the Philippines. The challenge is that we do not have adequate data, because in order to do that, you need to have extensive genome surveillance. Even in the United States, here they are struggling to model that properly. However, in the United Kingdom, in Denmark, in several other countries that have been able to do so, it takes about 6 to 8 weeks from when the variant is first detected for it to spread to become dominant, as in more than 50%. And what you will see, it's accompanied by a surge in cases as the variant becomes dominant. So the R will start to accelerate. For example, the B117, just by simply becoming more dominant, will add a 0.5 to the existing R, because it's just so much more transmissible. So in summary, we cannot do that modeling in the Philippines because we do not have adequate numbers. But from other countries, 6 to 8 weeks from when it becomes first noticeable, which we therefore expect sometime in April.
Thank you very much, Father. For Dr. Koch, Dr. Benji, if the variants take hold, would you advise cancellation of AstraZeneca and change the LGU orders to more variant efficacious vaccines from Billy San Juan?
That's an excellent question. I don't have an answer for that, because if you cancel the vaccine, that's the only available other vaccine that we have. And if they're for arrival, there is actually no other vaccine that is more that will address the same problem, unless we have one that will address the B.1.135. And correct me if I'm wrong, Father Nick, there is currently no vaccine that has completely addressed that particular variant. So the WHO actually recommends that if you have any of the vaccines, just administer whatever vaccines you have and provide it in the meantime. We are hoping that most of the vaccines that arrive, that have been ordered, do arrive, because that's the only way we can accelerate pushing the immune response of many of the people that should receive the vaccine. But I don't think we can cancel it. I'm not sure we're in that position to be able to cancel the vaccines at this point, because we only have one vaccine that is present. There are data that show that the inactivated vaccines, however, work better actually against the variant strains. And theoretically, the inactivated vaccines should work better than the viral vector vaccines and the mRNA version vaccines. So we have the inactivated vaccines currently.
So let me add to Dr. Ko. So there is evidence from Brazil. It has not yet been published, which is why it's so difficult to assess. But there is data in the news reports from Brazil that the Sinovac vaccine that we actually are already deploying in the Philippines is effective against the B1351 variant from South Africa. So I know there has been a lot of debate in the Philippines about the lower efficacy of Sinovac, which is an inactivated vaccine. And inactivated vaccines historically have lower efficacy rates, but their protection is broader, because as Dr. Ko pointed out, you are injecting the entire virus into the patient. So the other vaccines, you are only injecting the spike protein or a little part of the spike protein. And so what happens is a slight change and your vaccine is now very poor. But with the attenuated virus, you are injecting the entire virus. So even if there's a slight change, there's the rest of the virus that you can attack. And so again, surprisingly, given the conversation in the Philippines, when people ask me at this time, which is better, Sinovac and AstraZeneca, I say, given the identification of the B1351 variant in Pasay, in terms of the long-term goal, you might want to pick Sinovac over AstraZeneca, because even though the efficacy for Sinovac is a little bit lower than AstraZeneca, it will protect you against the B1351, while AstraZeneca will not. Now, let me also add to Dr. Benjamin Ko, one of the things that we do not know is whether or not even AstraZeneca will prevent against severe disease or death for B1351. This was not reported in the data. And as Dr. Ko pointed out, you would rather have some protection. So any vaccine will stimulate your immune system somewhat. And so if we have 17 million doses of AstraZeneca and we have to use them, then maybe we can go ahead and deploy them in areas far from the NCR, where hopefully we would be able to limit the spread of the 351.
Okay, thank you very much. Are there any data available about the efficacy of Sinovac vaccine against South Africa or UK variant?
So as I mentioned, we have data from Brazil that has yet to be published that suggests that the Sinovac vaccine is effective against the B1351. And the B117 does not actually experience immune escape, which means that the vaccines are actually effective. All the vaccines remain effective against the B117. And this is about the biology of the change in the spike protein.
I may add to that, that's the reason why the South Africa variant is called escape variant. Okay, based on what Father Nick was saying. And I did not want to venture on the data because it's not been published yet. The data from Brazil has not been published yet, but there is evidence that it is actually more effective for the attenuated vaccines, the inactivated vaccines against the variant strains.
Okay, for Dr. Austriaco, Father Austriaco, if AstraZeneca's efficacy decreases against super COVID variant, does it mean the other vaccines which use a double-stranded DNA technology like Astra will not be as effective too?
So I think my best way to respond to that is by not focusing on the delivery system, but actually what is delivered. So as Dr. Ko and I mentioned, the larger the target that is introduced in the patient, the more effective that vaccine is against variants. So AstraZeneca is trying to, it's using an adenovirus delivery system, but it's only introducing the spike protein. And so you can imagine that if a double-stranded DNA delivery system is able to deliver more than the spike protein, then it would have higher resistance. So it's not necessarily higher efficacy. It's not necessarily the delivery system, but the target that is being delivered that actually decides how effective a vaccine is against variants.
There's a question from Johnny Sinon. Dr. Johnny Sinon, HTAC does not recommend to 60 and above an HCW working in COVID areas. Your reaction to this, please? Any of the speakers?
Yeah, I think the answer to that is, well, that I was basically explaining that in the clinical trials. You see, some of the clinical trials are selective, which means that when you do a clinical trial, you only select certain patients. 18 to 59 years old was the target patients that most of these clinical trials were conducted in. And except for, of course, the mRNA, and AstraZeneca has also the same problem that they were not powered for patients that were more than 65 years old. So that became an issue in Europe. With respect to Sinovac, there is absence of evidence because of the clinical trials being limited to 18 to 59 years old. But you have to remember that the absence of evidence of efficacy for seniors is not the same as the evidence of absence. So absence of proof is no proof of its absence. So just because they say it's 18 to 59 based on the data that they have, but it's because they did not conduct the clinical trials in those more than 60 years old. So they didn't look into that. And it should work the same way. I would think it would work the same way. A healthy 65-year-old may have a better immunologic response than a 30-year-old who is not healthy in the real world situation. And that makes our immune systems differ in various ways. Remember, if you just use the age as a factor and say, okay, 18 to 59, if he is 35 years old, but he has diabetes, chronic heart disease, is on immunosuppressive agents, then that's a different matter to contend with.
And I'd like to add to Dr. Ko. So I'd like to add that the data from Israel that has the population-wide vaccination strategy, so they have vaccinated nearly half of their entire population. And the earliest data shows that the elderly who were included in the vaccination strategy, even though the clinical trials were not as extensive, they did not include as many elderly. When they extended the vaccination to the entire population, they saw very similar biological responses. So, just because you're old, you're still human. And so it's not expected that you turn 60 and you become an alien. So the biology is the same. So, and that is what we're seeing. I mean, this is something important to tell people who are not scientists. As Dr. Ko pointed out, we have expectations because we understand the biology of people. So we cannot recommend because there's insufficient data, but we can expect similar responses in our lolos and lolas. And this seems to be bearing out in Israel.
Thank you very much. For Dr. David, how long before the surge spills over to regions 3 and 4?
Well, that would be an interesting question. Right now, it hasn't spilled over in the entire Metro Manila yet. But it's spreading slowly. I mean, it's spreading quickly in the areas affected, like in Pasay and of course in Malabon, Navotas area. And how we answer that will depend on the effectiveness of the localized lockdowns being implemented in those areas, because we understand that localized lockdowns are there to stop it from spreading. We know, of course, that Malabon and Navotas are very close to Bulacan areas. Pasay may be fairly close to Cavite. Right now, it hasn't spread to, for example, as far down as Muntinlupa yet. So it could take some time, but it depends on how quickly it spreads out. So we can't really give an exact answer there. The modeling there is very tenuous. But if it does spread quickly, it could get there, within this month, within March. So I mean, that would be one possibility. I mean, it's possible to get there, to spread that quickly to those areas within this month.
Okay. Thank you. For Professor Rai, are you not in favor of MGCQ by the end of March?
Now, we're not suggesting that the situation is still manageable. What we do suggest is that we all take this rise in cases all around the NCR seriously. We need to adjust our behavior. Government needs to adjust its strategy and intensify testing, tracing, isolation. It needs to intensify or it needs to accelerate, but in a very efficient manner, the deployment of the vaccine for the most important resource of our healthcare system, our doctors, our nurses, and other healthcare workers. I'd like to put in some framing lang for everyone, for our media partners. OCTA is not suggesting either not to take one vaccine or the other. What we're talking about is what we learned from the efficacy and safety based on research. But we are one where there's a solidarity in OCTAT as a group to say that the best vaccine is the vaccine that's available now. We need to get our own health workers vaccinated. We need to get through our priority list as far as the vaccine is concerned. And whether it's AstraZeneca or Sinovac, okay, it's still better than not getting vaccinated at all. So this is our basic position as a group. Yes, there are differences and nuances to each of these vaccines, but they can be used, they will be effective, and that we encourage most especially our healthcare workers to get vaccinated, given the window of opportunity that we have at the moment, and given the reality that there is a surge evolving in the National Capital Region, and we want our most precious resource, our health workers protected from the possible negative effect of this surge.
Okay, thank you very much again, Professor Rai from Kaisent Magsumbol of Freeman, Cebu. Hello there in Cebu. Dr. Rai, your opinion po of continuing the use of public schools as isolation centers like what is done here in Cebu City, which the Vice Mayor calls as Jurassic.
The situation in Cebu is particularly worrying because Cebu is, first of all, let me preface it, Cebu is better prepared to deal with the surge. In fact, most local government units need to observe what is being done in Cebu. The last time they had a surge, it was very hard. They didn't have the resources. Treatment was still in its nascent stage. And, the testing, tracing, and isolation was still not in place, but they are in place now. And Cebu is, fighting very hard to deal with this vicious surge that has hit them, Cebu City in particular. Okay. And I leave it up, I respect the position of the Cebu City government. They have to use resources, okay, to deal with this surge. The idea is to try to reverse the surge, mitigate transmission. If it will require us using facilities, why not? No, and I leave it up to the best judgment of Cebu government to deal with, to decide on these issues. We respect that in OCTA, no? But the idea here is that Cebu is doing its share now. Cebu City officials, healthcare officials in particular, have been very, very heroic, as far as dealing with that surge in their city is concerned. We have a fellow there, Dr. Brian Lim, who is really a frontliner in Cebu, and is telling us that the healthcare system in Cebu has been working double time, to try to deal with the impact of the surge. Let's not close down. Even many local governments, if surges happen, will require using all available facilities to deal with the surge, including if it requires converting schools into quarantine facilities. Then, if that's needed, then we support all of that. But the idea there is how do we deal with the surge, and Cebu is doing it very well now. They've gotten hold of it. It's still not yet. They're still not yet out of the woods, but I think it's more controlled now than it was 3 weeks ago when it was surging and cases were increasing. Now they're managing, and we congratulate the Cebu City government, the cooperation between civil society, private sector, and the health, especially the heroic doctors and nurses in Cebu City who are, 24 hours working day and night, to ensure that the lives are saved.
Okay, thank you. Second to the last question, addressed to Dr. Ko from PTV's Sweden, Velardo Ramirez. If a person has already received certain vaccine, but later on it proves to be not too effective against a super COVID variant, would it be safe to get immunized with another vaccine brand that has a higher efficacy rate versus a super COVID variant?
I don't understand what you mean by saying that how you will be able to prove that it is not going to be effective or how it is less effective. Does that mean that you're going to get sick or somebody else gets sick? But let's put it this way. If you get immunized, you must complete your immunization, okay, for that particular vaccine. So if it is a 2-dose vaccine, for example, for Sinovac, then you must complete the Sinovac. There is no interchangeability study, which means that you cannot shift from one platform to another platform just because another platform has arrived. So you started with Sinovac, suddenly Pfizer arrives and you want the Pfizer vaccine. You will have to complete what you started first. If you want to get a different vaccine from a different platform, there are no studies that show that it will be more effective if you keep getting vaccines. But there is also no overdosage for vaccines. So with that, you can select to get another vaccine after you have received and you have completed your first set of vaccines.
Okay, thank you.
Can
And
I answer your question?
yes, doctor. And a follow-up question. J&J vaccine is being used by South Africa in place of AZ, AstraZeneca. Should we get these doses as well?
I think I answered that on private message. I said, good luck to us. I mean, it took us quite some time to even just get Sinovac. I don't know if we will be able to get that vaccine as well. Let's remember something, that there is a shortage in vaccines globally because manufacturing, we give it to more people than how many of the vaccines can get manufactured. And I think that is one of the gaps that we have in the country, that hopefully, I was saying that if we had a manufacturing plant, then that would have been advantageous for us. But it's actually difficult to just put up a manufacturing plant for vaccines locally. But and that's where you see the advantage also of certain countries like India, for example, where Novavax has all of their vaccines manufactured in India, and certain other countries that have advantages for their vaccines where they have a lot of manufacturing sites. But to answer that question, good luck to us if we are going to be able to get a Johnson & Johnson version vaccine.
Okay. Thank you, Dr. Ko. And with that, we would like to thank all our presenters from OCTAResearch. And we would also like to thank all our participants who have gathered in this activity. And we will hope to see you in another presentation of OCTAResearch for upcoming reports on COVID-19. Thank you very much, everyone. Have a good day.
Thank you so much.
Thank you.
Maayong adlaw.
Thank you.